Welcome to the Civic Leader Podcast. I am Sylvie Leger, and my guest today is Theodia Gillespie. And the topic that we will be discussing is health disparities and the social determinant of health. Before we do that, I'd love to introduce you to my guest, Theodia. Theodia is the president of and chief executive officer of the Quad County Urban League, and she took on this role in 1993 after serving as its education coordinator, director of education, director of employment, and program director. Theodia is a native of Missouri, graduate of Southeast Missouri State University, and you began your career with Quad County Urban League in '84. So 4 decades of dedication to the mission of Urban League. So thank you so much for joining. You have a passion for serving clients through education, workforce development. You've transformed the Quad County Urban League into a real affiliate by improving its operation, public perception, but also by really developing collaborative community partnerships and expanding the agency's profile across DuPage, Kane, Kendall, and Will counties. You're an outspoken advocate for equality. You are yourself a leader, and you are on the board of so many regional boards and organizations. And recently, you were appointed as co-chair of Education and Workforce Development Transition Team for the mayor of Aurora. So welcome. You're an innovator, you're forward thinking, and you are so committed to civic life and community. You've received several awards for your outstanding record of service. It's really an honor to have you as a guest on the Civic Leader Podcast. Welcome, Theodia.
Thank you. I'm glad to be here, Sylvia. Always glad to work with you. Love what you're doing.
Well, what's interesting is that you were really the catalyst for the policy circle to develop this brief on health disparities and the social determinant of health. At the very beginning, last year, in 2020, at the beginning of the pandemic, actually the world shut down. The day of your organization's summit, a women's empowerment summit, was the day where everything really shut down. I remember it clearly. And then since then, you've been able, like every organization, to pivot and serve your clients differently, virtually. And tell us a little bit about the Urban League and specifically the Quad County Urban League. The Urban League is a national organization. It'd be great if you share a little bit about that.
Yes. So we are, again, thank you for inviting me, Sylvia, to be a part of this important discussion. And yes, we are one of 100 Urban League affiliates throughout the country. We are all affiliated with our National Urban League office, which is located in New York. Our affiliate was formed in 1975, and basically that's mirrored with all affiliates throughout the country, working with individuals to provide them the tools, the support that they need to, one, obtain a career and then maintain that career. And that has been expanded by including a number of other things, which includes housing, education programs, and yes, even health initiatives, so that understanding that all these things allow our clients, our residents, to make sure that they can sustain themselves and their family. And what's the best way to do that is to make sure that they have the education, they have housing, and they are healthy enough to be able to maintain those opportunities for themselves and their family. So the Quad County Urban League, where our office is located in Aurora, we, as I mentioned before, started in 1975, and we provide education, advocacy, workforce development, which are mainly our signature programs. And during the pandemic, we realized there was other areas that our residents would need, such as emergency assistant and being able to navigate through this pandemic issue that we had in our communities. And so when you called me and told me that, just wanted to know how we were doing and that we had the Women Empowerment Summit and, where we're going to go from there. And I really appreciate it because it gave me an opportunity to think about how we can utilize our voice to really make an impact of the services that we're providing. So when you talked about pivot, we had to pivot everything in terms of how do we provide that direct services to our clients? How do we make sure that they have the tools and the resources to continue during this difficult time? And so I appreciate your work in the policy circle that impact policy, because that is also a service that we provide in terms of making sure that we have be the voice and provide the kind of initiatives that is important for our communities. So
Yeah, because you, as a leader of the Quad County Urban League, you are very involved with the government entities of
yes,
these counties, and also at the state level, you're really a known quantity and influencing policies that then are impactful, right, to
absolutely.
your clients. So yeah, it was interesting when we talked. You said the virus, the COVID-19 is really impacting communities. Each community is differently, and then you raised the issue, and you're like, we need, as a community, we really need to start paying close attention to our health, and have these open discussions about health disparities, but also how do we improve our health outcome. And this is how it really kind of sparked our interest in developing this brief, and because to give us a language to talk about health and what impacts health outcome. So what I would like to do is what we will be doing is going through a brief that was published by the Policy Circle, and you can find it at thepolicycircle.org. And the brief essentially presents in numbers what are we talking about when we talk about health disparities. What are some of the challenges, areas for reform, and at the end, ways to get involved and what we could do. So what we'll do is we will be going through the brief, reading and discussing and sharing information from the brief so that you can become more informed citizen and members of your business, your community, to really engage in closing this gap and ensuring that everyone in your community is healthy, and as it drives so many other outcomes. So disparities in health and healthcare across the United States reveal weaknesses in our country's health system. And understanding what these disparities are and how they originate and their effect on the health outcomes and the healthcare system can help determine strategies and policies that benefit the health of individuals, our communities, and then the United States as a whole. The Department of Health and Human Services, HHS, defines health disparities as differences that exist among specific population groups in the United States in the attainment of full health potential that can be measured by differences in incidence, prevalence, mortality, burden of disease, and other adverse health conditions. These are linked to social, economic, environmental differences ranging from concentrated poverty and insufficient access to healthy food, to limited transportation, exercise options, unsafe housing. The conditions in which people are born, grow, live, work, and age, referred to as social determinants of health, can have lasting impacts on individual and community health. So there's differences, disparities in the United States, and it's been really highlighted during the coronavirus pandemic. In April 2020, the CDC began reporting some concerning statistics. The Black community in Michigan accounts for 14% of the population, but accounted for over 40% of coronavirus-related deaths as early as May 2020. In DC, in Maryland, Virginia, the Hispanic population represent 10% of the total population, but over 30% of the coronavirus cases. And there were similar disparities that were found in New York, Illinois, Georgia, and in the Navajo Nation. The CDC notes that while the coronavirus does not discriminate, some communities have weaker defenses against public health crises. And it's shining, this virus outbreak is really shining a bright light on these disparities. So the brief includes a whole map that kind of illustrate these disparities across countries. Now, I'd like to kind of, maybe we could talk a little bit about that, and then the community that you serve with the Urban League during the pandemic. Theodia, do you have like some additional, direct experience with that? Did it impact really the counties that you serve?
All of those cities that you highlighted in the brief kind of shares that those are more urban communities, which means that there's not a lot of open land, there's not a lot of opportunities for individuals environmentally to be in a healthy community. And so very similar, and more so in Aurora, which is probably more the urban communities, and there's in the areas that I service, Aurora, Joliet, pretty much because they're more condensed. And so what we find is that when people don't have open space, the virus is more confined, and so you're more likely to be infected by it. That's why you see the communities that were extremely in urban communities and more rural communities, you didn't have as big of an issue.
Right.
So those are the things that we find. And the population that you're talking about of color, they tend to live in those communities, and they are basically our essential workers. So there are, folks who take care of our trains and buses and our transportation, who work for logistic jobs. So they're exposed a lot more. And during that time, many of us didn't know what, the whole country didn't know what we were facing with. And so we didn't know how to protect ourselves. And then a lot of issues that I noticed when we were looking at the individual who was passing away from that is their health conditions, these underlying health conditions, diabetes, high blood pressure, heart issues, overweight, obesity, which really impact communities of color because one, health-wise, we don't eat healthy food. We don't exercise enough, and you really find that, as I mentioned before, in urban communities. So I just think that was the biggest part that caused our community to be impacted severely behind this. And then, with the testing, a lot of people didn't know that they were impacted by this virus. So the lack of timing to get the health services that they need was a lot longer, and it got worse, or that they didn't have the services to go to a clinic or to the hospital, or have a physician that they can call to help them navigate through this virus during this pandemic. So, all of that to me played a major part in why our community was impacted so severely during this time. And so, yes, in urban league affiliates across the country, that was an experience. And then again, like I said, no one knew how to address this pandemic at that time. Everybody was trying to figure out what was going on and what we needed to do as a country.
Yeah, and it really shed a light on the importance of being just a healthy individual in order to fight this virus. And unfortunately, it's not something that we hear a lot about. We hear about the conditions, the conditions that make you a high risk for complications of the virus, but as a nation, we're not talking about what can we do to really improve our health so we could fight this virus and future virus that might come and be ready for it. So.
And I noticed in the brief, Sylvia, you talk about the education being where we start really into our schools. And so I had an opportunity to just get some insight from younger individuals about, what are their thoughts?
So why it matters. So the National Academy of Medicine estimates that medical care, the care you receive directly from a medical practitioner, accounts for only 10 to 20% of the health outcomes. And what are health outcomes? Well, health outcomes are measures of well-being, such as your quality of life and chronic disease burden. Do you suffer from a chronic disease? This means that at least 80% of health outcomes may depend on social, economic, environmental factors and their effect. If such a large fraction of health is left unaddressed, says CMS, the Centers for Medicare and Medicaid Services, it may increase the risk of developing chronic conditions, reduce an individual's ability to manage these conditions, increase healthcare costs, and lead to avoidable healthcare utilization. Greater shares of the population experiencing poorer health outcomes can significantly put the health of all Americans at risk by increasing public spending and healthcare costs. These expenditures can limit overall gains in quality of care. So there's one estimate by the Kaiser Family Foundation that disparities amount to approximately $93 billion in excess medical care costs and $42 billion, those are billion dollars, in lost productivity per year, as well as economic losses due to premature death. As calls to reform the healthcare system grow louder, it will be impossible to do so without understanding all of the factors that contribute to health. And like to put this, so this is just really the real dollars around these health disparities. And if we put this in context, we'll go through a few things. One is historically, so this became something that our government started to pay attention to in 1983. So HHS produced a report on the health of the US that indicated major disparities existed in the burden of death and illness experienced by Blacks and other minority Americans as compared with the nation's population as a whole. So this study prompted a government task force to conduct a study of minority health problems, which produced the report of the Secretary's Task Force on Black and Minority Health in 1985. And this was known as the Heckler Report after Secretary Margaret Heckler. She was the secretary of HHS. And the report offered a startling, compelling account of the prevalence of health disparities among racial and ethnic minorities in the US. And this was the first comprehensive government study of minority health status ever. And 1 year later, in 86, there is an Office of Minority Health that was established under HHS, and major healthcare organizations, including the Robert Wood Johnson and the Commonwealth Foundation, began addressing health disparities. So this is not a new problem. It's like over 30 years old, and that this is an issue. And the access to and availability of healthcare services, access to nutritious foods, access to education, employment opportunities, geographic location, all impact the rates of chronic diseases and overall well-being, and exist across all kinds of dimensions, such as gender, age, disability, socioeconomic, geographic location, etc. So taken in all of these factors as it relates to healthcare is crucial for developing policy solutions for all Americans. So there's a couple of things here. The brief goes through kind of the differences between the disparities that exist across these different dimensions. And one is access to healthcare based on insurance and level of population who are not insured, because the cost of healthcare and access to healthcare really leads to impacts health outcomes. So this outlines a survey, and just in a non-elderly population, the 0 to 64, for instance, there are like 22% of American Indians and Alaskan natives do not have insurance, and 19% of Hispanics and 11% of Black compares to 8% of white and 7% actually of Asians. So this is one of the metrics here, that access is one big issue, and there's a big difference. Theodia, do you have like some comment here on access to healthcare?
Yes. And so, many times that there's not enough physicians or healthcare facilities within our communities. Even during this pandemic, you have hospitals that's closing down in certain communities. So there's just not an opportunity for individuals of color to be able to get all of the utilization of healthcare services within their community. So yes, we see that when you don't have a job, because majority of our healthcare services is based on if you are employed, if you don't have transportation, you have to rely on communities, clinics, and they're not fully staffed or have the expertise that they need. If you're in a rural community, you don't have the best doctors. You have a lot of physicians who are just out of college and who may not have knowledge of some of the severe illness that impact our community. And then also understanding the different kind of illness that impact different race. Because all of us, our bodies are different. We respond to medicine and particular care different. And if you don't have that education or those skill sets in certain communities, then that is one form of, in my opinion, access to healthcare services.
Yeah, that's right. That's right. So here in the brief, also education and employment studies have shown that education and income level disparities are also associated, which is kind of what you're talking about, with chronic health conditions, as well as poor mental health stemming from navigating everyday circumstances and anxiety about insecure and unpredictable living conditions and a perceived lack of control. All of that actually impacts your health. There's also maternal health. So this is an interesting, according to the CDC, there's a 10-year study on pregnancy-related mortality, and non-Hispanic Black, non-Hispanic American Indian, Alaska Native women over 30 experience pregnancy-related deaths per 100 births at a rate of 4 to 5 times higher than white women. And in particular, chronic conditions such as hypertensive disorders contributed to more pregnancy-related deaths among non-Hispanic Black, non-Hispanic American, Indian, Alaska Native women than white women. And these differences hold regardless of levels of education and geographic location. So maternal health is also an area of disparity, of difference in health outcomes. I think you were mentioning as well, food insecurity was also another area, that households that do not always have access to enough food are referred to as food insecure. And in 18, the Department of Agriculture reported rates of food insecurities that were higher than national average, like 11% for Hispanic household, 16% for Black household, or national average is 11%, Hispanic households 16%, Black household 21%, and households with children headed by single women, 27% experience food insecurity. And so that is also linked to increases in chronic diseases, high blood pressure, to diabetes and cancer. So we'll talk a little bit more about that. And the last one, I think, in this brief that in terms of a disparity is geography, where between states, I thought this was interesting, life expectancy can vary by up to 7 years for males and 6.7 years for females. Even in smaller geographic area, there can be large disparities. So there's data from the Robert Wood Johnson Foundation that illustrates life expectancy between neighborhoods in Kansas City has differed by 14 years and even by 25 years in New Orleans. So there's some determining factors of neighborhood disparities that include, as we mentioned, food insecurity, but also violence, pollution, and the availability of resources such as hospital, transportation options, with Theodia you talked about, and then green spaces to exercise. So those are all kind of dimensions of disparities, areas of disparities. And then we'll go into like, okay, what are the things, the reform, the areas where we can make a change. So I think this confirms, what you were saying about what you're seeing across urban leagues in the U.S., right?
Mm-hmm. In regards to, all those things that you talked about, transportation creates problems for being able to have a healthy lifestyle, being able to have access to grocery stores with fresh vegetables, and in low-income families, they have a tendency to really purchase stuff that will last a lot longer, prepackaged foods, not necessarily eating fresh vegetables or fresh fruits and things that, because the shelf life on those types of items doesn't last too long. So they're trying to keep the stuff in their cupboards or their refrigerators that last for months or a month or more. So, and without having that healthy lifestyle, we will continue to have these issues. And it's not just having access, it combines with everything that we need to do in order to make sure that we take care of our bodies.
Yeah, I mean, health is such a personal, it's at the it starts with the individual, it starts with the family, it starts in the home, and then it's the community. And we had an initial discussion, policy circle discussion with several women around Naperville on this topic. And they were saying the influence of peers and the influence of your community to push you to have a healthy lifestyle. And I think that's really interesting. And it's something that's very personal and community based and needs to be embraced by a whole community, not just pockets, right?
Yeah. So we have to just, educate and show, expose what that looks like and what that means, the outcome for themselves and for their families. And a lot of times we don't know.
Yeah. Well, so the next section here is about the role of government. And this is it's very interesting, actually, the federal government. So the 2020 fiscal year budget allocated over $1.3 billion to treating chronic disease and addressing health disparities, including like $984 million to chronic disease prevention and health promotion under the CDC, 900 million. Okay. 335 million to the National Institute of Minority Health and Health Disparities, $65 million to the Office of Minority Health. So there's an Office of Minority Health under HHS, the Health and Human Services, that is tasked with research, investigation, data collection, shaping policy, programs, practices that raise public awareness, and building networks, coalitions, and partnership. There's also the Patient Protection Affordable Care Act, ACA, reauthorized the OMH, that's the Office of Minority Health, in 2010, and further established offices of minority health within 6 other HHS agencies: the Agency for Healthcare Research and Quality, the Centers for Disease Control and Prevention, Centers for Medicare and Medicaid Services, the FDA, the Food and Drug Administration, and the Substance Abuse and Mental Health Services Administration. So each of those agencies have an Office of Minority Health. And then the National Institute of Minority Health and Health Disparities under the National Institute of Health also raises national awareness about the prevalence and impact of health disparities through its research, programs, publication, partnerships. So there's a lot that is being done at the federal level through multiple agencies, and there are links here to see who are members of the various council. There's even a National Advisory Council on Minority Health and Health Disparities that's composed of community representatives, health professionals, subject matter experts, who advises the HHS Secretary and the NIH and the NIMHD directors on health disparities. So the federal level, there's resources, there's attention of all the agencies, and even just like to highlight within Congress, in the legislative branch, there's a number of committees that influence healthcare through oversight and spending allocation. So in the Senate, and this is helpful to know because you could look at your senator and your congresswoman or congressman and which committee they're part of and subcommittee they're part of and their ability to influence health. So there's a Senate Committee on Health, Education, Labor, and Pension that has jurisdiction over most of the agencies under HHS. There's a Senate Committee on Finance that includes a subcommittee on healthcare that has jurisdiction over programs including Medicare and Medicaid and other HHS programs financed by taxes. And then in the House of Representatives, there's committees on oversight and reforms that oversees federal agencies with subcommittees on healthcare, benefits, administrative rules that oversees all these agencies. And then the House Committee on Energy and Commerce has a subcommittee on health that has jurisdiction over consumer protection, food and drug safety, public health, and environmental quality. So there's a lot of attention at the federal level. Do you have a reaction, Theodia, to this data, this number, this effort at the federal level? And then we'll go into the state and local, which you have much more experience on.
Yeah. So when I was reading the brief and I'm seeing all these support, but I think the problem that we have is communications, and then who is actually, setting these policies and what impact that they have locally, because everything should trickle down to your local community, right? And I don't think that's because every community is not the same. Rural communities not like urban communities, suburban communities not like urban communities. But I think it's been too much focus on like a cookie cutter solution versus really looking at the region and what needs to be done with those resources in terms of research. One of the things I talk about is that, there's not enough research individuals that's part of the research that looks like of individuals of color. And if you don't expand out and make sure you do more recruitment, I think there's been some efforts of lately of that, but the recruitment of individuals that you're really trying to target, but really focus on the different areas of regions and not necessarily a cookie cutter solution in how they support. There is a lot of resources out there, but I don't know how directly they're getting into the communities that really need to be part of that or part of that research so they can better service them through all those health initiatives.
Yeah. And I think this is where, when it comes to the state, so the Office of Minority Health has partnership grants for the state and tribal health offices and agencies to address health disparities. So this is where I think it's probably like block grants that are made to the state, and then each state have their own Office of Minority Health and they do their own report. So I kind of followed the links here in the brief to look at, what Illinois is doing. And there's a substantial report in the state of Illinois, and there is an office for health minority there. So the question is, okay, how is that money used then to actually, like you said, go to the community and get people and get each community to create their own solution and approach to health. And it always goes back to having a leader and a champion. So it's kind of interesting. And just like I said, like partnerships have seen unsteady level of fundings across the decades, but overall there's grants to improve minority health that ran between 2010, 2013, that was 5.4 million that were allocated across the states. And also around 15 to 20, it's another $4 million across the state. So those are kind of the grants that have been given to each of the states. And there's a whole report, like the OMH has a report by state of all of the differences in the health disparities. So there's tools out there to really understand what your state is at and what it's doing. So, and maybe you have some experience there at the state level. Right. I'd love to hear that.
It's important to get involved. And if we have questions, because for me, it's been really a learning experience for all of us. When the pandemic came down, it's like, what's out there? What's available? How can our residents navigate through all the support that they need to really combat whatever issues they may be going through? So I agree that we also need to be more educated as what's out there and what we need to bring back to our local communities to make sure that our residents have what they need.
And it sounds like, when reading this, what I find fascinating is just it really boils down to having a champion in the community around health. Like it needs to be embraced by a neighborhood and say, well, we are going to be about organizing races, having, bringing in, gyms or different events or activities that are around a healthy lifestyle. And that requires a lot of leadership. It's not easy. It requires resources, but just really leadership and foresight.
And I think, it shouldn't necessarily be one age group. I think we need to engage our young people a lot more because they seem to be more environment conscious, healthy lifestyle and eating more so than in my age group. And I think they need to be our champions, saying this is what we need in order for us to be more healthy and more successful in our pursuit through adult life. Because we see so many young people that are overweight. And I think we begin to really have that candid conversation that they need to be the champion, as you said, the leaders
Yeah.
driving discussion.
And it's hard. It's hard to get them to embrace it, right? Because there's so many distraction, so many everything. All the attention is turned to really playing video games, watching Netflix, watching TV. Like it's hard to say. Okay, yeah, it's going to be, exercising. It's hard to be healthy. It's hard work to be healthy. It's hard.
Absolutely.
Yeah.
It's absolutely. And then, of course, all the gym closed down. So we really don't have.
Yeah, right. That's the other thing. That's the first thing. Like, let's close something down. Let's close the gym. First thing that comes to mind, which baffles me. Right? So there's a section here about the private sector. And I think it's interesting, like non-government hospitals, university, community organization play a large role outside of partnership with the public sector. And faith-based and other community organizations help empower individuals at the local level and bring these individuals together to act collectively. The private sector also has the potential to improve employee health by communicating with employees to determine how to best promote health equity among employees and what existing community resources may support this endeavor. So there's some examples here of community outreach and patient empowerment programs that was done with the Navajo Nation Community Health Representative that has an outreach program that bring healthcare teams and community advocates to create programs that focus on barriers and gaps in community healthcare systems. So there's a lot that's done. And I think there's one resource that's outlined here. The University of Michigan as a library compiled resources and publications and research on health disparities in the U.S., including a list of health equity organization and resources. So there's a lot. Universities have developed programs, and there's a lot of resource there. And I think it's always about the implementation, which is the challenge, and also to have it top of mind. I think it's interesting here to say the private sector having as a company, when you have your team, putting health in the forefront. So I don't know what you guys are doing as a team to promote health, if anything. Are you guys doing something?
So yes, we are, and like when you said you had to pivot, how you do business now, all of us had to do that. And we had to pivot in terms of, how do we bring information to our clients? And that's by partnering with our local grocery stores, showing them how to navigate, through different cooking habits and vegetables. Does not take a lot of work to do, and just really keep emphasizing that we have to change our lifestyle. I mean, if we didn't have that opportunity before, this is the opportunity now for all of us to say that health is so important for our future and for our well-being and for our communities. And so it's partnering, and you hit it on through the brief, is that it takes collaboration. It takes all of us in our communities to really put the pieces together to make sure that we have the resources for our residents, to make sure that they have access to those things that's going to keep them healthy. So that we won't get into the same situation again. But it takes collective collaboration of all of us and making that happen. And so that's what I've been kind of focusing on, what my partnership should look like, and ensuring that our residents have what they need, and our clients that come to our office, and pushing that as well. So, and we're going to start with our young people. We are absolutely going to start with our young people, just to really, for them to understand that, yes, you have a situation now, but this is what it may look like 10 years or 20 years from now. But if you start now, you don't have to deal with those issues. And I think if we start with the education, it's what I really love about the brief in terms of the disparity and what we need to do. That is the key. That is the key, and working together.
Yeah. So it's interesting. So here in the brief, there's this section around the social determinant of health. And there's a graphic, I think that was published by the CDC, that says what goes into health. And I love this graphic because at the bottom, and we said this when we in the introduction, 20% is the healthcare. And then there's 30% is health behaviors, which is what you're talking about, right?
Absolutely.
Health behaviors and what your diet, alcohol use, tobacco use, sexual activity. And then there's a 10% is a physical environment, a healthy environment, that quality of air. And the 40% is actually your socioeconomic factors, your education, having a job, your family, your income, the community. And so I think like this, and then we'll go through in more detail, but it's a great graphic to realize, okay, it's not just access to healthcare. There's 80% of other factors affect health outcome. And we talked about clinical care, the timely use of healthcare services. We talked about health deserts, where there are areas where there's not enough, there's just no hospitals, and especially in rural area and low income communities, there's a real difference in communities and access to healthcare. And then I thought it was interesting. There's a physician shortage, where there's a prediction here that, we will have a shortage of 140,000 clinicians by 2033. But there's also this difference between urban and rural areas, where there's even a greater shortage of doctors, and then in different neighborhoods based on socioeconomic neighborhoods. So the physician shortage is a huge issue, and the coronavirus pandemic made the challenge of physician shortage an immediate concern. Yeah. And a number of states addressed these shortages by modifying their licensing laws to allow healthcare professionals to offer their services across state lines, and also to really expand the availability of telehealth services. So there's a hope there, and I think that's a little bit of a silver lining of what happened in the lockdown, is that telehealth became so much more available, but physician shortage is a big issue. Now, are you doing, with Urban League, with the education, are you promoting healthcare career in health, and developing the workforce in that field?
Absolutely. And, trying to figure out how we can best finance our young people's education, because I think that has created the cause of a lot of the shortfall, not being able to financially afford to go to nursing school or go become a physician. It takes about 10 years of your life, individual graduating from college with 6-figure debt. So, that economic piece where they just don't have the resources to go to school.
Yeah, and right. To go to school for that long also. Yeah.
Absolutely. And so the ideal is to try to find out ways that they can trickle their way to pursuing those healthcare profession. And one being what I've been focusing on is, let's try community college first. That's not as expensive, and then just work your way up, because that's where the challenge is. It's become overwhelming when you got to focus on education and, trying to get a college degree and then financing that. So, and then partnering with the different health facilities and universities. And, there's an organization here called Visiting Nurses Association, where individuals can start, their profession that way, being in community clinics so they can learn and exposing them. So the ideal is, yes, our partnership again is in those particular areas, but also making sure that they have the finances for that education.
Yeah, and there's also, the other piece to that is really having the incentives to encourage people to go to communities where there are shortages, whether it's rural communities and staying there, or vulnerable communities, and having the incentives for people to actually work there, right?
And they do exist. Some of those incentives do exist. It's just that a lot of doctors don't want to go to mainly rural communities, but that's where the most need is.
Yeah. Yeah, no, that's right. So we talked already a little bit about health behaviors, which are actions that are taken by individuals that affect health or mortality, such as smoking, physical activities, sleep, adherence to medical treatment. And these behaviors are linked to personal responsibility just as much as they are to social and economic conditions that shape or limit choice. So there are statistically significant negative relationship between active travel, walking and cycling, and self-reported obesity, as well as between active travel and diabetes. However, available infrastructure, roads, sidewalks, safety can influence personal decisions about active travel. And this is something, this is where health is, we realize when we start unpacking health and looking at this brief, we kind of see the complicated web, how everything is so interconnected. Because if you don't live in a safe community, how can you go out for a run or for a walk or for a bike ride? How can you expect people to lead a healthy lifestyle? And it kind of goes back to safety, and to me, that's, community impacts your behaviors.
And I remember being able to go outside and play and not have to fear of being kidnapped or in the line of gunfire. That has impacted many of our communities. That the safety pieces that kids don't go outside and play. That for those various reasons why whether it's in a well-to-do community or whether it's in a area that's is high in crime. And that's so unfortunate. Those opportunity miss. And so that's why I think, partnering with different like parks, teaching our families, hey, take your child to the park, give them an opportunity to run around and play. You can't let them like, hey, go outside and play. You can't do that anymore. But really just kind of emphasizing the importance of going to the park and making sure that our parks are safe so that families feel safe and utilizing. So, if we don't have, those type of communities, then we need to educate. And I keep saying educate because I just think that's just been a huge piece, Sylvia, in terms of, encouraging parents to understand how do you raise your child in these kind of
Yeah, and it's
environments.
modeling, right? And it's
It
also, I
is.
think it's, you kind of, when it comes to health, it's really through your actions that you can educate the best, right? So you have to model like health is a priority for our family, and we take the time, and we take the time and the effort and the sacrifices that it requires to the self-discipline that it requires. I think it's the other piece, and it's
That's a
really
key
hard
word.
when you
Yeah.
don't have those models. It's really hard to do.
Yeah. So you're an inspiration because you do practice those healthy lifestyles. The way you eat. Focusing on exercise. And you're right. We all have to exhibit those behaviors, so other people can see that. And then let's
Yeah.
not make excuses. I think most of the time we make excuses why we can't do anything, and that's the biggest of our
Right.
problems.
It's easier to talk about it. It's like just
Yeah.
a funny aside. I worked on a project to develop an app that was called Food Fitness, and the app was really to help caregivers increase the level of activities of people with disabilities, with intellectual disabilities. So it's simulated in the app, very simply going to the ballpark, and we were showing the app, and it was really interesting when people realize, oh, this is about exercising, and people would be like, oh no, I don't want to know anything about it. It was very strange. Like people, I couldn't believe it. I thought, I'm like, my mind, like everybody wants to exercise and everybody is excited about doing more, And then it was
Yeah.
like, caregivers were like, oh no, I don't want to do this.
Yeah.
So it's a mindset, and with all the opportunities and the tools and the apps and the online services, and still we don't do it, right? Like, I mean,
Yeah.
because it's hard.
Yeah.
Because it's hard. It takes a lot.
And then, of course, here we have cold weather and you're not outside.
Yeah.
We don't have long months that we can be outside, many months so when we're
Yeah, no,
inside.
it's definitely it's hard to model. I mean, it's the pinnacle, I think, of a self-discipline, and it's really hard to model for everyone. I always admire elderly people who are like, I walk, my 100th step a day, or like that have this routine and needs to be part of a routine. So that's
Well, I'll give you a
it's
good example. I had my family over, and we were talking about how many steps we need to get in. And then there was another niece was saying, I want one of those. So I think the more we talk about exercise and fitness, I think it will click.
yeah.
That it's basic, going up down your stairs in your house, or just walking around every once in a while. Get from behind your desk and just walk.
Yeah.
Build those steps, which is moving around is part of keeping yourself limber and being able to have some mobility.
Yeah, and creating these small competitions, right? The number of steps and competing against each other.
Mm-hmm.
So the other piece here is lack of trust. So this was interesting. This came out, this idea of lack of trust came out when we were developing the brief and having a kind of a pre-policy circle around it. Around like 10 people shared a personal experience that really brought distrust in the health system. And these were personal experience. And then so the policy circle team went out and kind of did a little more digging there in terms of, is this real? Like, what's happening? So this is interesting. The lack of trust in the healthcare system is an important but often overlooked factor. There's an Emory University study. Hispanic and Black respondents were more likely to report believing that doctors don't see them as equals, or were less concerned for their well-being. Another research initiative by the Robert Wood Johnson Foundation found that low-income patients, uninsured patients, family caregivers, and non-English speakers all reported widespread distrust of the healthcare system and the feeling that they were seen as less than by healthcare professionals on the basis of their income, insurance status, race, language. Physician behaviors such as brushing off patient concerns and symptoms and ignoring adverse events that patients reported from prescribed treatments have been linked to stereotypes, racial profiling, and implicit bias, according to the Association of American Medical Colleges. On the patient side, histories of biases and poor treatments, such as the Tuskegee syphilis study, have contributed to and perpetuated that trust. So rebuilding confidence in the healthcare system requires an understanding among healthcare professionals that trust is not automatic. And so there's initiatives to train doctors on how to address the social determinant of health. And there's also the Accreditation Council for Graduate Medical Education is a private nonprofit organization that reviews graduate medical education programs, and their sponsoring institution has made sensitizing medical students and fellows to health inequities a priority in its medical staff. So in its accreditation system. So this is an interesting concept, and there's a great video here from Florida International University Neighborhood Help Program that tried to really get medical students to go and visit people in their home to really understand fully what contributes to why a patient is not following their treatment and what is happening outside of the medical office. So I'd love your perspective of that, because I think all of us, and perhaps more women, and it's cultural, it's family, your trust in the care system is really individual, and everyone has different experiences. But it was interesting that, these 10 women, we all shared an experience of distress, and then it kind of gets validated, and it's a topic of research. So I'd love your thoughts and reaction to this idea.
Well, and so, the history, with like you said, the Tuskegee experiment, and, when you live in a culture that that story comes up over and over again, you start building those mistrusts. But then when you go to a doctor, and I've been experiencing that as well, Sylvia, is that go to a doctor and they're prescribing all of this medication. I'm like, well, wait a minute, all of a sudden I'm just sick. And it's the trust that they're not necessarily focusing on your health, but financially, from the pharmaceuticals, pushing out pills. And sometimes these pills have all these side effects that makes you worse than it was before you went into the doctor's office. And so you're not looking at what makes a person whole again for their illness. You're only looking at the financial part of it. And that's what's happening with certain communities. When you go into a doctor and they break it down very simple terms, that's when you begin to build the trust. When you go into a doctor that gives you all these medical terms that you don't know nothing about, it's just foreign to you. And then you think, are you really looking at my health? Are you looking at, just giving me some words and say, okay, this is what you're going to do, but I'm not getting any better. So we have to, and I will agree when it talks about, accreditations, the doctor's behavior, they used to call that bedside manners. That's what people want. They want people to look at them and say, you really care about me.
And the whole person, right? Not just the one disease, right? It's take everything into account.
Right. And so we have to begin to start making sure that we have physicians that not necessarily when you can afford, I can afford to go to my doctor or go to a doctor that cares about my health. But there's so many families or individuals who do not have that opportunity. So that's one of the pieces we have to build to make sure that all physician understands that you're working with a human being, and that human being needs to understand what's going on with them, and that you're really focusing on their health care. The same with the vaccination that's trying to be pushed out. I can't believe, just a number of even family members saying, I don't want to take it, I don't want to trust, because we have to begin to build the trust in our communities. And I go back to when we talk about research, that African Americans in particular do not participate in research. And so because they don't trust. And the only way that physicians and the health industry understands what makes our body function and why we respond to certain things that others may not respond, that we have to participate in that. So that's another thing that in terms of encouraging our communities, that research is there for a reason, is to make us better. And we have to begin to build the trust. And so there's organizations like myself and other organizations that we work together to build that trust factor in our communities, that the only way that we're going to get better is that we participate in these things, and that we understand understand the science and what that means to our overall health.
Yeah, and it's. I think you bring up an interesting point that you have to participate in those studies in order to be to be taken into account and to modify studies. So yeah, so education. So the other social determinant is education, and there's like two sides to education. One is, studies, and AEI found this study that among working men who self-reported having fair to poor health, research revealed that a 16% gap between those with less than a high school education and their college education counterparts in their health, self-reported health level. So there's a link here with education attainment that greatly affects the knowledge of how to access, understand, appraise, apply, advocate for health information services. Your education level. And then there's the other piece about health literacy, which is that education about how the healthcare system, which is what you were talking about. And health literacy found like lower level of health literacy correlated with increased hospitalizations, greater emergency care use, lower use of mammogram, poorer ability to interpret labels, and among seniors, poorer overall health status and higher mortality. Health literacy really impacts impacts your health outcome and your ability to seek health and understand. So that's what we've been, you and I, you've been bringing this up, and I think this is what's really interesting in this brief. And I think this is something that each of us can really play a role in our community, whether it is in our school to find out, what are we teaching in terms of health, in our job, and then just in the community at large. So I thought that's a very interesting topic. There's in the brief here, there is a link to a project that's called Project Share curriculum. It is a curriculum that was developed by the University of Maryland in Baltimore, and it aims to build high school students' skill to reduce health disparities at the personal, family, and community levels. There's a link here to a whole curriculum that could be adopted. So there's resources there, but I'd love to hear your thoughts here around education and perhaps what you've seen function in or outside of schools.
So because you and I talked about this before, that we really need to make health a major focus in our education curriculum. And when I was going to school, we had health, we had for real health, and then also physical education. It wasn't that, oh, you can just read this book and then you do physical education, but looking at that whole approach of how we focus on health and not necessarily, just let's go to the doctor and he's going to put me all back together. And so when I shared with you that I had talked to some young people, and I said, well, what are you thinking? And they're like, absolutely, health. She talks about, understanding your body. If something goes wrong, what that means? Do you make an adjustment? And I think that's what happens when people have the fear of going to the doctor. They're going to hear something bad. That if they go to the doctor, they're going to tell me I got cancer, or they're going to, I got, just heart. And so that is another form of fear. But if we start, as we've talked about in this all today, is educating. And if we can educate in our schools, start at a young age, where they understand, not at high school, but start even at elementary. Because I have friends who said, oh, my daughter told me that I shouldn't use these cleaning because they had so many chemicals in there. And, maybe I wouldn't have lung disease. So young people were telling her children were telling her these are bad things for her health, for their health, environmental. So when young people start telling us, telling their parents, these are things we need to do, we will listen, because we want, kids normally don't talk, but when they start saying something that, maybe we can think about that's important. So if we education and that utilizing those part of the curriculum, and when you read a book, it's focusing on healthy lifestyle. If whatever they're doing, every year that we keep emphasizing health, the importance of healthy lifestyle, that makes a huge difference. And then we don't have that fear factor that we have now, not wanting to go to the doctor, waiting until we're like, ready to die before we think that's important for us to go and get checked out. And then making sure that, we have the questions. When we go into the hospital or to the doctor's office, we know what to say about what's going on with our body.
Yeah. There's also, I feel like the other piece is how to navigate the healthcare system. I'm an immigrant here, and this was something, I was very afraid of coming here when I was in my 20s. It was like, oh my gosh, how does this function, right? And I think that's the piece of how do you navigate the healthcare system of having a primary care physician and having an annual exam, and then where you go from there, and there's specialties, and how you need to advocate also for maybe more or less testing, but to know how the system functions. I think that this is sometimes something that is missed, and in a way that you need to cover in high school or community college, to graduate from high school, so that you know what to say when you need to get a physical in order to go to college or get a job, or what words do you use? I feel like we need to emphasize that, and not only the specifics of health, right? Like sexual health, drugs, mental health, all of these pieces, but then how does it all come together, and how do you manage your health is a component of health literacy that sometimes we forget.
No, and I totally agree in terms of how navigating through all that process, understanding their body, and then if you have a headache, take an aspirin. If it gets worse, maybe we need to go to and get it checked out at your physician office. But you're absolutely right. It's understanding the system in order to make sure that you are on tap with making sure you're in good health, and preventative care is what I always emphasize. That's something that we don't fund, preventative care in this country as much. But that's what we need to be able to teach about. What is preventative care? What did that look like? What did that look like?
Yeah. So the other social determinant is employment and income. So there's a graph here, that shows that the more higher education that you have, then the job, you will be, there's a correlation between education, employment, and income. So low skilled, low income workers are more likely to find themselves in jobs that do not support good health.
Right.
And this can be in terms of physical environments such as agricultural, construction sectors, where workers face numerous safety, environmental, respiratory hazards, and jobs that do not support good health can also reflect salary, security, health, and social benefits. So there's inequities, in employment are also associated with demographics. And so, for example, like Hispanic workers comprise 17% of the workforce, but account for over 50% of both agricultural and construction industry, and are much less likely than white, Asian, Black workers to have access to paid leave. And then Black workers make up 12% of the workforce, but 25% of service industry employees, and less than 1/3 of workers in service-related occupations have access to paid sick leave. Mm-hmm. So this is also, the access to employer-sponsored health insurance difference is also another factor into the difference in health disparities, is the jobs and the income, and the level of employment as well. Mm-hmm. So there's a whole section around that. There's also, maybe one thing to highlight, there's a business group on health, is an organization that addresses the healthcare issues facing employers, focusing on the healthcare policy, creating sustainable employee well-being programs, and designing leave programs. So there's current members that include Aetna, LabCorp, Allstate, FedEx, Fitbit, Marriott, among others. And Marriott International has a Take Care program that focuses on providing employees with opportunities to make healthy choices through fitness challenges, nutrition lessons, stress management technique, financial well-being services. And then Marriott extended this program to associated organization teams and communities where they operate. So jobs, education, and then jobs also have an impact on health. The last two sections are, one is around the environment, where people work, live, and spend considerable amount of time, greatly affect their sense of security, well-being, opportunities, and then behaviors in those communities. So that's another real impact, the environment and the safety of those. There's different initiatives to, of course, improve safety so that people can walk and live active lifestyles in their communities, and then there's nutrition. So maybe before we get to nutrition, Theodia, do you want to react to employment and environment? Talked a little bit about that already, but maybe you have additional thoughts.
Yes. So, we run a workforce development program here at the Urban League. And so the idea is to find a career where they can provide opportunities or sustainability for themselves and their family. And so the way our healthcare system, how we pay for healthcare system, is based on, what kind of job you have, where do you work. And so that is a huge piece of the health disparity. And so the ideal is that we want to encourage individuals to be able to pursue careers and opportunities that will give them those stability within their household. The other piece is, when we talk about the environment, is that homes are in urban communities are a lot closer. They don't have access to open space. That's what happened with the pandemic, that those who were in close confinement areas were getting more infected than those that had land around them. So we just need to, again, figure out how we can best educate our communities how to utilize some of our public facilities where they can have a little bit more open space. And then, teaching our families how to own a home. Those who lived in apartment buildings, again, that was because of the close confinement. But we just need to, one is to figure a better way how we can provide healthcare to all of our residents in our communities, and then to make sure that giving them the opportunity to understand different careers that will give them a little bit more resources to take care of themselves and their families. And then understanding that, owning a home, is better for them versus renting in an apartment. You have the open space, you have, not being so confined to an area that's not healthy for you. So, those are part of things that we're incorporating, budgeting, financial literacy, how to be homeowners, how to be better prepare yourself for opportunities that's in your community for yourselves and for your families, and making sure you have the right education that to be able to pursue and be comfortable. And that's why we, in our workforce development programs, we want to expose our clients to those opportunities, show them what it looks like before they even start. And so, which has worked out really well in terms of them feeling good about themselves. And once people understand that they can do it, the sky's the limit.
Yeah, right. And it's great that you focus on, here's what it could look like, right? Here's how your life can improve if you pursue these career options, like the change in everything in your life. So that's great. So the last piece here is around nutrition. And this is really interesting. Like in the US, the 10 counties with the highest number of food insecure households all spanned urban cities, including our town, Chicago, Phoenix, Los Angeles, Houston, New York, and limited access to grocery stores also exist, of course, in rural areas. And predominantly Black and Hispanic neighborhoods also frequently have fewer supermarkets and grocery store than predominantly white and non-Hispanic neighborhoods. And instead, these areas tend to rely on convenience stores that generally have less variety of food, inferior produce, and higher prices. And these regions that often feature large proportions of households with low incomes, inadequate access to transportation, and a limited number of food retailers providing fresh produce and healthy groceries for affordable prices are called food deserts.
Right.
So this is really interesting how there's a real correlation between access to like food insecurity, poor diet associated with higher rates of chronic diseases, cancer, diabetes, hypertension, obesity, and in children, birth defects, developmental problems. And the opposite is true. Also, there's a University of Washington Center for Public Health Nutrition found that closer proximity to supermarkets was related to consumption of more fresh produce, lower levels of obesity and diabetes, and lower body mass index. So this is really interesting. And in the brief, I love this video. I don't know if you watched it. There's a video about Ron Finley, who's the urban gangsta gardener who started growing his own food on small strips of grass outside his home in South Central LA. And his project helps community embrace the act of growing, knowing, and sharing the best of the earth, fresh grown food. I invite you to watch this video, Ron Finley, the urban gangsta gardener. It's really great. So, we talked about nutrition, and is this something that you've seen communities really come together and advocate for bringing maybe farmers market or a grocery store to a community? Have you experienced like good examples of changing the course here?
Yeah. So a lot of the farmers market allow families to bring in their food stamps. I guess they call it a link card, and then there are gardens where they can go in and either plant their own food. And then what I think is so important is canning. That is such an old-fashioned way of preserving your food for the winter, storing your food for the winter. And I don't think we've done on that. I've talked to some individuals about doing that. It takes time. I would love it because there's nothing better than fresh food that you can get out of the garden. And when you talk about some of the desert, some of the pesticides that goes into some of our food, some of the preservatives that trying to keep the vegetables fresh or the fruit fresh is just not good for our bodies. So I think that's what we're trying to do. I know here in Aurora, there's a lot of garden plots where the individuals can go and grow their own food. But and then they provide the seeds for them, so they don't necessarily have to purchase the seeds. That they allow them to understand what it means to really utilize fresh vegetables during the course of the summer. Again, in this area, we don't have a lot of warm months, but it's other ways that we need to teach, and even myself, how do we grow herbs and things during the course of the winter, so that we still have fresh organic food. I know a lot of grocery stores now are focusing on organic, which is good, and that's again it's those pesticides and preservatives that cause a lot of our health issues.
But the first part is really access to fresh produce and knowing how to prepare them and eat them. So it's people eat it. Yeah. I mean, this is
And then once they start eating and know what it tastes like, hopefully they will want to. That's the taste that they want, not the
yeah.
preservative and those packaged foods that's not good for us.
Yeah, no, I thought that was it's a really interesting concept, and I feel like the brief concludes with community-based solutions, and there's a great example of the Indianapolis Congregation Action Network. It's called IndyCan, and now I guess it's called Faith in Indiana. That had a really community-based approach to really get the community mobilized around creating a mental health unit instead of prison. So to get people who suffer from mental health issues to get the right treatment and in their communities instead of just being sent to health. So this is a good example, and kind of the brief concludes where you and I started this conversation around that health really comes back to what are we doing in communities, because it is so personal and so depends on personal responsibility initiative to change the health outcome.
Mm-hmm.
And it's interesting. I feel like this brief, I don't know if you feel the same way, Theodia, but I feel like this whole list that we went through, from nutrition, employment, education, health literacy, this becomes kind of almost like a scorecard that if you are an organization, an individual who want to make a difference, move the needle around health, this becomes your scorecard and saying, well, what do I want to impact? Is it education? Is it health literacy? Is it employment outcome? Is it nutrition and access to fresh food? This is the list, and this is where you can make a difference.
And prioritizing, the different entities of what makes to address all of that inequity. It's dealing with situation like mental health. What does it look like in African American community for so many years? Didn't think it exists, that they just kind of push it off the side, but it's a major problem, and the pandemic has amplified a lot of mental health issues in our community. So it's understanding what it is, what it looks like. Again, all those entities, when I talked about employment, having the resources to provide opportunities for your family, for yourselves and your families, eliminates all of those issues that cause individuals for not having a healthy lifestyle, or not being healthy, or not having access to health services. So just checking all those things out, saying this will make you a healthy individual for yourselves and your family and your for community. I just think if we're just healthy community, it makes us stronger. People working, people giving back or investing into their communities. So you building a strong entity where everybody can live, work, and play.
Yeah. No, and when you look at ways that things that you could do and ways to get involved, I think like it starts with measuring, like finding out like, okay, what are the issues of health in my community? Where are we at? Well, how many, just what is the state of health inequities in my community or in my state? Like measuring and then identifying what's already going on. We said before at the state level, there's state minority health offices that can be contacted to kind of understand, well, what's their priority, how are the resources distributed, and really identify who are the influencers, who could be allies to also take on this health issue as a priority, and then being a catalyst, kind of reaching out, building a coalition, reaching out to your representative at every level of government and also in the schools, depending on which button, which lever you want to really activate, and planning, setting out some milestones, and then really executing. And I think here in the brief, it's interesting. There's a health equity action plan that kind of has like 7-step guide, and also there's different tools. There's a health impact assessment tool that can help measure the effects of a proposed policy. So there's lots of resources, things you can do, and hopefully, this conversation, and thank you again, Theodia, for participating, inspires you to really look at health differently and more actively in your life and in your community. And I'd like to conclude with this quote from the Robert Wood Johnson Foundation. When people prioritize health in personal decision-making and public policy through a growing sense of community, robust civic engagement, and awareness of one's own health affects others, how one's own health affects others, health and well-being can flourish both locally and nationwide. So I think it's a real key to everything, and everything relates back to health. And this is an important conversation, especially in 2021 in the midst of still this coronavirus pandemic. So thank you, Theodia, for
I've enjoyed
doing this and for being a catalyst for this conversation and this whole topic. That's that's what I love about the policy circle. It just allows me to engage in conversations like you with people like you to then turn around and say, well, I need to learn more and really activate efforts around this. So thank you.
and influence change. That's what I like about the policy circle. It influenced change. Yes. So thank you for the conversation, and I look forward to working with you another time.